Hello, I hope I'm loud and clear. Good evening, everyone. Just confirm you can hear me. Are you able to
We
hear
can
me?
hear you, Ken. Yes, we can. Pass on Nadia
Okay,
Ken.
great. If you can hear me, then I think other people can also hear me. It's another day that we thank God for this moment. Um, we want to welcome all of you again to our continuous uh, knowledge in sharing. Um, we've been having series of neonatal nutrition, and today is day 3. I hope learning is taking place and you are learning something new. So today we are continuing with the series. We promised yesterday that we'll be looking at the neck. My colleague Grace Nyawira is experiencing challenges with power. I think there's issues with power blackout in our area. So I'll be stepping in to cover the sessions that she was to cover today. Hopefully, she'll be able to join us again in the as we continue with the series. I also want to let you know that we'll have a case study at the end of this, so that we can rewind on what we've covered for the 2 days and see if we can easily tackle them. So you are welcome and feel much welcome. Kindly, you are free to post your questions or any concern or any addition in the chat box, and make sure your videos and mic are muted so that you don't interfere with the network of other people. So yesterday, just to pick a recap of what we learned yesterday. Yesterday we look into details the parenteral nutrition for neonates, and we were able to look at SPAG and also the NIS guideline, what they're saying. And I hope it was an eye opener for us to learn a lot about the parenteral nutrition for neonates. And you are also able to see that. Indeed, the three macronutrients play a key role. That is the carbohydrates, the proteins, and the amino acids in for the neonates. And also, we were also able to discuss that it is important for us to calculate the energy requirement using specific guideline requirement. We learned that also micronutrients should not be uh, overlooked. Underlooked when we are coming looking at parenteral nutrition for neonates, because they play key role for that. So today we promised that we'll look at something called nutritional challenges for preterm, those which are quite common. I hope you'll be able to follow up for the few cases that we'll discuss. Then finally, we'll wind up the session with a small case study that we have. So today we'll be looking at nutritional challenges of preterm and low birth weight infants. Basically, our objective will cover, we try to describe the nutritional challenges of preterm. We'll describe the medical challenges and their implications in nutritional management of preterm. So just to open up this session is that many infants experience a lot of medical related challenges and even surgical related challenges for neonates, and these conditions many a times affect the feeding and basically have a higher impact on the nutritional status of our neonates. So it is important for us to really learn today how what type of this what type of nutritional challenges our neonates experience and how can we really overcome them. So, nutritional challenges of preterm. So, one is high metabolic rates. Usually, neonates experience quite a high metabolic rates, and this is one due to accelerated growth rate. Is one of the issues that is linked highly to high metabolic rate. Of course, we have higher proportion of more metabolically active organs like the heart, the liver, the brain. So at neonate stage, infants tend to have increased and rapid growth of vital organs like the heart, the liver, and brain. And this require higher nutrients intake. And therefore, this will have a higher metabolic rate for most of the neonates. So one aspect of high increased metabolism, what we call hypermetabolism, of course, is accelerated growth rate, and of course we have the aspect of the proportion of metabolically active organs. So metabolically active organs are liver, are heart, and of course we are talking about the aspect of brain. You are all aware that almost 60% of the feeds that we take is utilized by the brain. So therefore, with that note, the neonates are usually at a higher risk of requiring increased energy intake. Then, of course, we have inability to maintain normal body temperature. So this is because of lack of adipose tissue. So many a times neonates experience the aspect of hypothermia, and due to that, they therefore require increased energy intake. So many a times their skin is not so turgid, and therefore they don't have enough adipose tissue to help them in insulation of their body, and this really will require them to have increased energy intake. So another one is of course excessive water loss. Due to the nature of their skin, so there is a higher osmolarity of water escaping through the skin, and this is due to, of course, high permeability. So, very thin skin with high permeability is one of the reasons that neonates always experience challenges. So, these three ones are very critical things that we need to have. One is, of course, hypermetabolism, and this is coupled with the increased growth rate that the neonates experience, higher vital organs which require increased energy intake. Then, of course, we talk about the aspect of body temperature. Of course, there's aspect of regulation, and that's why if you enter the NICU, you find that it is quite warm. The temperature there is quite warm because we want the babies to be as more insulated as possible. And even those who cannot withstand the open air, the room temperature and all that, they end up being put into the incubators because we want to preserve as much body temperature as possible. And of course, the last but not least is the aspect of skin permeability. So with their thin skin, they have increased evaporation, and therefore the fluid tends to escape quite often. So, nutritional challenges of preterm. So, we'll look at them, quite a list that we've listed here. We might not be able to look at all of them, but just a sample common ones. So, the first one, of course, is very small stomach capacity. So, immaturity of digestive functions is one of the key things that neonates experience. Remember, the digestive organ is one of the critical organ in matters digestion, it matters absorption, and it matters even transportation of the nutrients from the digestive system to the liver for metabolism. So neonates very often experience very small stomach capacity. At that moment, if you overfeed them, then they might end up having challenges. And again, if you underfeed them, again, it's another aspect. So that's why calculation is very key. You can't be working in NBU and then you can't be taking your calculator to do some calculations. NBU and NICU is one of the areas that you must do calculations. So feeding is much important, and due to the small capacity of the stomach, therefore you need to calculate how much you're giving. So very small stomach capacity is one of the digestive challenges. Of course, we have slow gastric empty and stool passage. Many a times neonates experience delayed passage of stool, and this can be coupled, of course, by either indigestion or their stomach juices is not able to break down the hard component of the breast milk, and of course some of the feeds that they get. It cannot do that as easy as it is required. So many a times they have delayed empty and stool passage. Of course, we have slower upper and lower intestinal motility. So this takes time because, again, most preterms do not have their digestive system is not fully developed, and therefore the aspect of peristalsis is not usually achieved. We talk about what we call intestinal fragility, a high risk of neck, and neck in full is just a necrotizing colitis. So most of this is very, very common condition that neonates experience. and of course that is due to the fragility of their intestine. Of course, liver immaturity, low bile production. So I hope up to this moment we are able to understand how bile is produced. It is expected that red blood cells take 120 days before they are broken down. So many a times for preterms, their red blood cells usually you find that they die before the expected 120 days. And it is expected that after the red blood cells are dead, they are converted into uh, they get into the liver, where they got converted into what we call stacobilin, urobilin, and of course the bilirubin. So all these are excreted of outside the body. So many times you find the liver of the preterms are not able to adequately break down these the dead red blood cells, and this one as is due to maybe the liver was not um, uh, fully mature enough. So again, the aspect of bile production, low bile production. Remember, bile is produced in the liver and then, of course, stored in the bile duct, where it is now used for fat emulsification. So this also might have a higher impact, higher challenges in aspect of of the digestion of fats. Of course, we have digestive enzyme deficiency like lipase and disaccharides. So lipase is responsible for digestion of lipid, and of course, disaccharides enzymes are usually common. Yeah, all of you understand that digestion of carbohydrates starts in the mouth through the salivary amylase, and of course, when there is a partial digestion, then when it goes to the stomach, then we have the aspect of it being broken down from gastric amylase and all that. But again, polysaccharides are broken down to disaccharides, and then of course in the stomach we find mostly of what we call disaccharides enzymes. So we have deficiency of that. Of course, lipase is responsible for breakdown of lipids after emulsification by the bile salts. So you find if we have deficiency of lipids, then therefore the babies are at risk of even having steatorrhea, which is passing of uh, of um, of fat in stool. Immature digestion and absorption of carbohydrate, protein, and lipid, therefore high risk of malabsorption, especially fat. So that again goes back to the point number, the previous point that we've discussed. So the preterms experience immature digestion and of course absorption, and many a times they experience malabsorption, especially fat malabsorption due to deficiency of lipase enzyme. We have inability to coordinate suckling and swallowing, of course, due to breathing. So they are not in a position, most of preterms are not in a position to balance breathing and suckling at the same time. So they sometimes either forget to suckle because they want to concentrate on breathing, and sometimes they forget to breathe when they are concentrating on suckle. So there's usually what we call inability to coordinate the two. We expect that they can still suckle at the same time they breathe, and that for preterms is not very common. Low esophageal sphincter pressure. So many a times you find that the pressure from the esophagus. Remember, the stomach is elastic muscles that, of course, through the process of peristalsis, the feeds are able to move downwards. But so if we have low esophageal sphincter pressure, therefore, you find that the feeds will move slowly to the stomach, and therefore this is one of the commonest preterm challenges. We have GI tract sterile and therefore immunological immature. So we expect that the GIT, of course, have live probiotics and prebiotics that are able to also help us in digestion and also help us to avoid malabsorption. But most of the time, we find that the GI tract of preterms are sterile, and therefore the immunity, they are so much immunocompromised, and therefore they experience a diarrhea. So these are some of the challenges, nutritional challenges of preterm that you need to have idea of. I hope majority of you, maybe in the chat box, you can mention which ones have you come across, and we'll be able to see, interestingly, what you've seen so far. So those are some of the nutritional challenges of preterm. Of course, that one, the first one we had looked at is on the aspect of digestion. Then again, we need also to look at other organs, how they are. And the next organ that we look into is the immaturity of the renal function. So remember, preterms, many a times their organs are not fully developed, and therefore their renal challenges is one of the key issue they experience. And of course, this one, we have limited capacity for concentration of urine and elimination of waste product. So you find we have a high accumulation of waste product because the kidneys are immature to offer enough ultrafiltration. So glomerular filtrate rate, you find sometimes is affected for preterms because of the the nephrons, which are not so mature enough to help in the aspect of water reabsorption, and of course excretion of waste product. We have aspect of vulnerable to excess renal solute overload and dehydration. So you find, because reabsorption is not properly done, so you have a lot of solute within the kidneys. And again, you also having aspect of dehydration, because again the absorption is not well coordinated. The aspect of renin, angiotensin, aldosterone system is not adequately achieved. The RAS system is not adequately achieved, and therefore you find these babies have challenges with renal functions. And that's why it is important for us to do UECs frequently. And of course, we talk about ability to maintain acid-base balance. So sometimes you find we are not able to really uh, maintain the normal oncotic pressure within the kidneys. This one has a higher challenges in maintaining acid-base balance. So that is when we talk about the kidney. So for digestive system, we've seen quite a lot of problems they experience. And of course, for the renal function, that is what they experience. Then we have conditions affecting feeding and nutritional demand. So you find maybe renal and digestive system are not the only problems that preterms experience. But again, there are those external, I can call them exogenous factors that can also affect the feeding and also the nutritional demand of preterms. One of them is poor suckling and swallowing refluxes, only developed at 32 to 34 weeks gestation. So you find preterms born below that, they might not be able to suckle adequately. So because of that poor suckling and swallowing reflux, of course, we have poor tolerance of feed and potential aspiration. So this is very common for neonates, and sometimes this is why sometimes we insert NG tube to help just in feeding, because sometimes many a times they experience aspiration, and this, if not well looked, they can also end up having aspiration pneumonia. We have fluid restrictions imposed. So out of the ordinary, due to maybe protocols that are not well clear, you find many a times the aspect of fluid restrictions for neonate, for the reason not well understood. It could be maybe there are no well protocols in the facility that maybe people are working on, and therefore they restrict fluid. And we've seen that the neonates are quite prone to the aspect of dehydration, and of course they lose a lot of fluid through the skin, which is impermeable. We have aspect of mineral and micronutrients, low level of calcium, zinc, iron, and others, most accumulated in the last 10 weeks. So it is important to note that some of the key ions are usually transferred 2 weeks prior to delivery, and many a times for preterms, they might not be able to have these adequate micronutrients transferred fully from the mother to them, and therefore they usually have micronutrient, mineral and micronutrient level are quite low. And of course, generally fewer nutrient reserve. So for compared to term babies, preterm do not have adequate nutrient reserves. This is of course due to the early delivery, and therefore they have not been able to accumulate enough store in case maybe after delivery they cannot go for a long period without feeding. So after looking at that, I would like us to look at high growth rate and nutrient accretion for neonates. This is very important for us to learn as we try to look at some of the key problems that neonates experience. So we have growth and increase of body calcium in fetus between 25 to 40 weeks of pregnancy. So we all know that calcium plays a key role in the aspect of bone density growth, and of course the aspect of preventing the convulsions and also the ataxia that is coupled with hypocalcemia. So for 40 weeks, we have 800 grams, and of course, you can look I mean, for 25 weeks gestational is 800 grams, and at 40 weeks, 35 grams body weight. So if we have that, then of course, the height at 25 weeks is 30 centimeters, at 40 weeks is 50 centimeters. And then, of course, we have uh, fresh weight of brain, of course, as 75 grams. A baby born at 40 weeks has 375. Then, of course, we have body calcium level is around 5,600. You can see a big difference between a baby born at 25 weeks and also a baby born at 40 weeks. So the demand, the deficit is quite big. So all in all, you can see that the term babies have a higher per hand compared to the preterm. Looking at all the parameters, that is the body weight, the length, of course, looking at the brain and also the aspect of calcium. So the preterm babies are quite disadvantage. So the growth rate of fetus during the last third of pregnancy is higher than in any later period of life. So the third trimester is where there is quite higher growth rate. It by far exceeds the high growth rate of first year of life. So when you compare the first year of life and also the third trimester, you find that the growth rate is quite high at the third trimester. So looking at increasing body weight of up to around 4 times within 15 weeks time period. So you can find there is a quite almost a double more or triple of the normal weight when you compare to the first trimester and also the third trimester. Of course, weight gain of full term is double by 6 months, and of course, we triple at 1 year. So if a baby is born term, at 6 months, we expect that they'll double up their weight. Then, of course, at 1 year, we expect that they have tripled their weight. So I think that is some information which is very key, and I hope it is something that you continuously monitor for those who have babies at home or who come to the facility. Now, we've looked at nutritional challenges and quite a number of them, looking at the digestive challenges, renal. We've looked also what I term as exogenous challenges that the babies experience. Let's now dwell into some of the medical challenges that preterm experience. One of them, of course, is respiratory. So respiratory distress syndrome is one of the commonest uh, preterm challenges that they experience. This is, of course, due to immaturity of the lungs, so they are not able to have enough gases exchange. And of course, we have chronic lung disease, i.e. bronchopulmonary dysplasia, what we call BPD, is also another common challenges, and this also have a higher impact on their respiratory function. Cardiovascular diseases is one of the commonest. So we have what we call congenital heart diseases. Example of them is what we call patent ductus arteriosus. It's quite common congenital heart disease that is seen in preterms. And of course, this is also coupled by so many causes. We also have um, uh, they also experience aspect of the unclosed aorta and all that. So patent ductus arteriosus is one of the commonest cardiovascular condition, and many a times these babies, they have what we call failure to thrive because of the congenital malformation that they're experiencing. These are the kind of babies you'll feed them, but the weight gain will sometimes be static. You'll not have much improvement. And I know they are the conditions that many nutritionists tend to run away from, because we like to see weight coming up, and when we have babies whom we see that there's nothing coming up and weight gain is quite static, and even after they have achieved the 1,500 grams, you still, even at discharge, when you are doing follow-up of them as outpatient or maybe in our clinics, these are the babies that usually give us more stress, and many a times people are afraid really take care of them. Of course, we've talked of renal, so fluid and electrolyte disturbances. Hyponatremia, of course, is one of the things. Low sodium level is one of the things that we experience. We've discussed also renal as a nutritional challenge. Neurological disorders are also quite common medical challenges like apnea and intraventricular bleeding. So because of gain of the immaturity of the vessels, so you might have them rupture. So this is very common. Then gastrointestinal, we have hyperbilirubinemia. Of course, this you can see by either jaundice, either pathological jaundice, which is quite common for this. And of course, we have feeding intolerance, necrotizing enterocolitis, which is neck. I think we'll discuss it in details. But basically, neck is the development of necrosis or tissue death of intestine. So most of it is a significant cause of morbidity and mortality in low birth weight infants. So neck is one of the most commonest mortality reported morbidity and mortality for low birth weight infants. So it is of course, it is a multifactorial combination of inadequate tissue, oxygenation, and of course, bacterial overgrowth playing a big part. So neck has quite a number of factors coupled together. One, we say that we can have inadequate tissue oxygenation. So you'll find that the tissues in the GIT are not getting in the intestine are not getting enough oxygen. And of course, sometimes many a times we've looked at the immunocompromise of the GIT. So we have bacterial overgrowth also, which plays a bigger part for preterms. So neck is associated with enteral feeding, and it strongly influences enteral feeding practices. Patent ductus arteriosus is also another key that we've seen. So neck is quite common, reported. I will look at it in details. I've explained patent ductus arteriosus. Of course, this is during fetal life. A major portion of blood flows bypass the unexpanded lungs. So you find that the 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 the, the blood bypasses lungs, and of course, they go straight to the outer. And these babies, usually we term them as blue babies many a times. So immunological medical challenges, of course, sepsis, pneumonia, and meningitis, quite common. Um, uh, Reported medical challenges that neonates experience. Of course, ophthalmological retinopathy of prematurity is quite common. We have hepatic immaturity and others like bradycardia. Of course, bradycardia, we are talking about low heart rate, and of course, cyanosis, the oxygen. With the oxygen, so we expect them, they have blue babies, and of course, osteopenia due to the challenges of bone issues. So, what are some of this effect, the challenges we've just looked at? What some of the what effect will they have to nutritional management? So, the additional medical challenges will affect the nutritional management of low birth weight infant. One, may create the need for fluid restrictions. So, for example, if we are having challenges with the renal functions where we have fluid overload, you may restrict fluid for these babies, and therefore, so remember we say that they lose um, more of fluid through skin permeability. But again, you find that if you now restrict that fluid, again, those are some of the challenges you may experience. And of course, will contribute towards the increased nutritional requirements due to hypermetabolism. So if you have nutritional challenges combined with medical challenges, like maybe the patent ductus arteriosus, then you'll experience quite a increased nutrient demand. And of course, this can affect the tolerance of enteral tube feeding. Yeah, so for example, if you have neck, you'll not have adequate enteral feeding, and this one again, it affects the tolerability of that. And of course, may delay initiation or temporarily interrupt enteral feeding. So, for example, if you have a neonate diagnosed who was just a preterm, of course, and then later on they develop neck, that might interrupt the normal feeding, or may temporarily interrupt the enteral feeding. Now, I want us to dwell deeper into neck because we promised to look at it yesterday. So today I would like us to really look at neck in details. So necrotizing enterocolitis, by definition, is an inflammatory disease of small and large intestine. It is combined with death of intestinal wall, what we call necrosis. So anytime you see medical term neck necrosis, of course, is the aspect of tissue death. So it is an inflammatory disease of the small and large intestine. So you can imagine if small and large intestines are all affected, you know very well that absorption will be compromised, because after digestion is complete in the stomach, of course, we from the upper part of the small intestine and lower part of the small intestine, we expect the aspect of absorption. So, and of course, water reabsorption in the large intestine is very key. So with neck, all these are going to be compromised. So this could lead to perforation of the intestinal wall, and of course what we call peritonitis, where the fluid escape to the perineum, uh, peritoneum cavity. So this is very, not perineum but peritoneum cavity. So this is quite common. So you might have inflammation of the peritoneum cavity. Then of course neck contributes to high mortality. Many a times, sometimes if you it delayed in diagnosis, many a times the patient, the preterms end up dying early. Of course, very small premature babies are at higher risk. So small for gestational age are quite common, are the ones that experience common. So very small and small for gestational age are the mostly common at high risk of neck. And then, of course, risk include immature fragile gut, aggressive feeding. So if you start feeding babies at a higher rate without doing proper calculation, especially for preterms, then that is one of the can lead to necrotizing enterocolitis. Then, of course, we have hyperosmolar feeds, the feeds that have of high osmolarity. We have malabsorption of carbohydrate, which may lead to bacterial overgrowth. Remember, bacteria feeds on sugar. So if you're having malabsorption in the GIT, then the bacteria will be able to start feeding on that, and that can cause necrotizing. Of course, poor oxygen and blood supply to the gut. Of course, for premature preterm, of course, for preterm, this is very common because maybe the blood vessels to the GIT might not be fully mature. So nutritional management, of course, breast milk is protective and feed of low osmolarity. So breastfeeding is quite key, is key for uh, babies, because remember, breast milk has what we call immunomodulators, and therefore they'll be protected. And of course, we encourage that you start feeding with low osmolarity. So it is important to do the calculations. You remember day one, Grace was able to take us how to do those calculations. So this is what we are talking about neck for in preterm. So this picture is a true pictorial representation of necrotizing. So preterm infants with necrotizing enterocolitis, a syndrome of acute intestinal necrosis of unknown etiology. So you could see the color of the skin there. It means that we have also have poor oxygenation. You can see the blood vessels are quite prominent there, and the stomach is protruding because of the challenges of constipation. So presenting clinical features of neck, of course, are abdominal distension, abdominal tenderness or rigidity. The patient experience lethargy, hypotonia, and apnea. Hepatic portal gas on abdominal X-ray. If you do abdominal X-ray, you'll see hepatic portal gas. Of course, intramural gas, what we call pneumatosis intestinalis, or abdominal X-ray. So you'll see gas within the intestine. Then, of course, we have intestinal perforation. So basically, you can have holes within the intestine, and of course, blood or mucosa in stool. So these are some of the clinical presentations that you can see. So in conclusion, there are so many preterm problems that are there. And of course, we've looked at both nutritional and medical challenges that preterm experience. But one of the commonest conditions that we've looked at, of course, is neck. So premature babies have nutritional challenges, which of course include hypermetabolism. They have inability to maintain normal body temperature. They have immaturity of digestive system, and of course, they have renal function is compromised. There are also medical challenges, so like respiratory We've talked about respiratory distress syndrome. CVD, we've talked of patent ductus arteriosus. Of course, they have renal neurological condition, immunological issues, GI conditions, ophthalmological condition, hepatic, and others. So these challenges affect nutritional management of preterm and, of course, of low birth weight. So with that, I'll stop there before I go to the case study, maybe for any question or any addition to my presentation. Do we have any question or any addition? I'll be glad to take that before we go to case study, just to look at what we've covered and if we can do some examples. Any question? Comments? I can't see anything in the chat box. Good. So if we are all good, then allow us to look at some case study here. So I hope you are ready with your pen and everything, and also you can because you are the major people who are going to be involved into this. So I'm going to, it's a small case study that we are going to look into. So this is the case study. So we have baby Y is brought to the hospital with poor suckling reflex and poor breastfeeding during day 6 of life. Birth weight is 2,000 grams. On exams, the patient, of course, is jaundiced. A febrile, temperatures is 39 degrees. Current weight is 1,820 grams. So the first question, what is your first impression? This is open for discussion. What is your first impression? Okay, I can see there are some questions here. Okay, I could see there are 2 questions. So let's tackle the case study, then of course we'll come back to the questions that have been put in the chat box. So anybody who will try the first impression?
Hello.
Yes, yes.
Okay, so my name is Nancy. I'd like to try. I think my first impression will be dehydration because baby's not feeding well. Then, okay, other assessments that I think should be conducted, maybe UECs to check if there's hyponatremia or hypernatremia.
Yeah.
Then calculating the feeds, I think I'm not really sure, but I'll start from 60, 80, 100, but 140. Then the first feed I think would be less, like trophic feeds first, or even fix an NG. Yes, I think someone else can continue from there.
So your impression is dehydration? Your first impression?
Yes.
Okay. Because of course the patient has not been feeding well. Is there any other thing? Of course, we have poor feeding. I would like to hear what other people will say.
So yes, my name is Joanne.
Yes, Joanne, go ahead.
Yes, my first impression with this baby first will be hypoglycemia. I think we'll first have to fix the hypoglycemia first, because most of the time, babies who do not breastfeed very well, they tend up to have jaundice. And this baby is doing day 6. And we have even noticed that there's a weight loss. There's weight loss. So we'll first have to deal with the hypoglycemia first for me. And then the first day that we were being taught, the baby is 18, 20 grams. So, and there is also poor feeding. So we'll start at 60 meals I think I'll do my first day at 60 mils of the current body weight. Yeah, I think someone else can say.
60 minutes of the current body weight. Wow, interesting. Okay. I'm loving this. I don't know why Grace is not here today. I hope she's in. Grace, if you are in, just tell me you'll be also following it up. Somebody else, I've seen comments in the chat box, of course. We have the people giving impression of neonatal jaundice, neonatal jaundice, stroke early neonatal sepsis, stroke dehydration. Of course, there's breastfeeding jaundice. How can the baby have febrile with the temperature of that? Oh, okay. That was just that was an oversight or Orifa. Of course, the with that high temperature, the babies the temperatures are high. So of course that is there. Check sugar, do UECs, okay. Neonatal sepsis, dehydration. I'm interested in knowing the gestational age. Is this a preterm or term baby? Quite interesting. Okay, so I brought this case study. Anybody else? You can unmute yourself and talk. All right. So I think the impressions that you've given is, of course, is mostly correct, because of course this history is not comprehensive. So definitely will what we see in this baby is, of course, high aspect of hypoglycemia because of the poor feeding. Remember, we are going to experience dehydration in this baby. Of course, the neonatal jaundice is there. High chances of neonatal sepsis because of these temperatures. You don't know the kind of infection this baby is having. And we are doing day 6. So the first impression is what is important. I know Joanne has already even go further, and of course Nancy has also gone further in the calculations of what we need. So what other assessments should be conducted? Number 2, question 2. So question 1, the impression. What other assessments should be conducted? Anybody, you can unmute yourself and you give us the answer, or you can type in the chat box. If you say blood works, what are these blood works? Velma Amondi, you kindly state them. Of
Hi,
course.
Okinda.
Hi, Esther. How are you today?
Thank you. How are you?
I'm doing fine. Go ahead.
Okay, for me, we'll do RBS, check the sugars, do UTs. Also do maternal, look maternal, how is the mother generally? Maternal nutrition also, how is the mother attaching and every other thing? Do you have enough milk, like breast assessment too, to see if there's an issue with the breasts, the letdown? Yeah, that will be what I'll do next.
So you'll do RBS, Yeah, just to check
RBS,
the sugars.
UECs, LFTs, na
Okay.
maternal assessment.
Okay. Great. Remember, there is no like a fixed answer on this. We are all discussing just to remind ourselves on the previous. What somebody has talked about ketones. What about ketones? I would like Nyokabi Judy to really elaborate on us. Which test will we do to see ketones? If you can unmute yourself, we'll be happy to hear more about it. So we have people saying, of course, we'll do UECs, we'll do full hemogram. So what are the probable, looking at this case, what are the probable findings in the UECs? What is the likely finding in the UECs? Let's start with the UECs first for learning purposes. Okay. So what are the probable findings that you are going to find in the UECs? Both, you can talk of elevations and maybe low values. So we anticipate high sodium. Okay. What else? Somebody, of course, has stock MPS. Of course, malaria parasite, you can do that if the baby is coming from a malaria endemic area. So that is also very important because it's something that many times we can overlook. So we can expect high potassium. Okay. What about other things in UECs? Great. I can see also we can do culture sensitivity, CRP, of course, just to check the level of inflammation going on if we do CRP. So high creatinine, of course, liking this, high sodium level, deranged electrolytes, increased urea, and creatinine for dehydration. Great. And let's look at the full hemogram. What are some of the key things that you are going to look into for the full hemogram that will be of interest to you? Full hemogram, there's white blood cells. So what about white blood cells? What are the probable findings for this baby, for the white blood cells? Of course, to check infections, I agree, it is to check infection. I would like to see what are the expected values that you might get from this. Of course, white blood cells to check infections. What about, what are those specific things that you do? Elevated white blood cells. Yeah, so that is exactly. So you might find that the white blood cells are quite elevated, of course. We've looked at what other parameter will we be checking in the full hemogram? I've seen HB. So HB, what are the anticipated values? You can also unmute yourself. Sometimes those who cannot type, it is good that you can unmute and also talk. It is good. So do we anticipate low HB, high HB, or what are the values? So for HB, of course, low HB for jaundice, okay. Hematocrits, okay. So low HB, complete blood count, that's okay. Of course, sometimes you can, platelets is also very important to have a look into. Now, liver function test. What are the key parameters that you are going to look into in the liver function test? We are still in the lab works, biochemistry, liver function test. What are those specific tests? I'm doing this intentionally because I want to see if we are really good in doing the full assessment. So we are at the biochemistry. So liver function test. So what will these figures tell you? So of course we have total bilirubin, GGT. Okay, or if I like to hear more about GGT, what we'll talk about, total proteins, direct and indirect bilirubin. Okay. So what about them? What about direct and of course albumin level and bilirubin levels in the liver function test? So what about them? What are the probable findings that you are going to have? Let's start with maybe direct bilirubin. High, low, or what for such a baby?
The bilirubin levels are going to be high.
Okay. So we anticipate elevated bilirubin levels. Okay, so what might be when we are looking at the brain of this child, if you have elevated bilirubin level, what is that condition that might cause to the brain? I like to see who got it right. Elevated bilirubin, what are most of the probable brain complications that we are going to experience for the baby? Encephalopathy.
Hello.
Yes, go ahead.
Can you tell us? Yes.
Can you expand more on it for those who might not know about it? Nancy, are you still there? Yeah.
Okay.
Why you say?
So, so what happens? I think it's the direct bilirubins are lipid soluble, but I'm yet to confirm. Let me confirm first so that I don't
Okay.
give
You don't give. Yeah, this is medicine, so
false
we
info. Yeah.
thank you, no problem. Of course, we anticipate the aspect of encephalopathy. That is quite common. Of course, so the baby might experience seizures, of course, because of the elevated that. Well, so thank you very much. I'm seeing, so we have quite good practitioners in this class. Now, let's do number 3. We are doing calculation. Calculate the enteral nutrition feeds in the first 24 hours. I remember Joanne had said that she will start the 60 or the current weight. Joanne, what reason do we have, or what guideline are you following? And of course, Nancy has said we are doing 140, if I'm not wrong. So John, I don't know if you'll unmute yourself and give us why would you start at 60 of the current weight? Any reason?
Let me just correct myself.
Okay.
It will be 60 because the patient is above 1.5 kgs.
kg.
So it will be 60 day 1 times I think it is the weight that is the highest. We are supposed to calculate with the highest weight. So example, if our patient was 200 grams and he comes to the hospital with 1820. I don't know. I am here to learn. Let me see what you say.
Okay.
I get quite confused there because some other people say it is the current weight, others says it is now the most weight that the baby has attained.
Okay.
Yeah.
All right. So Nancy, you talked of 140 per kg. Let's hear what you mean. And Esther Karanja, always start slow to avoid refeeding. That is not accurate. Remember, here we are doing calculation. I need figures. I need figures coming out here. Tell me how much is this. We start slow. What is this slow? I need values, Esther Karanja. I'll be
Then can
interested.
I
Jen,
start?
Jerry. Yeah, go ahead, Jen.
We start with 60 mils per kg body weight, and then we increase the total volume by 20 mils per kg per day until the baby is taking a total of 200 mils per kg per day. And that is from the guidelines, the BFCI and BFHI guidelines.
Guideline.
Yes.
So
And then you're
six.
supposed to do 8 to
Remember,
12
our baby is doing day 6 post delivery.
post delivery, and this is
Yeah.
for babies who weigh less than 2.5 kgs.
Yeah.
And remember, this child was born a low birth weight baby because hakuwa amefika 2.5. So the guideline says you do 60 mils per kg body weight, and then you increase the total volume by 20 mils per kg body weight until the baby is taking 200 mils.
Okay.
And you can do the meals per 8 to 12 feeds, that is 2 to 3 hours. 2 to 3 hours, yes.
Okay.
But I stand to be corrected.
Of course, we are all here to learn.
Yes.
Okay, great. Anybody else? Anybody else? Let's hear what the people would like to say. So you can see that we are having different thing. So I think since there's dehydration and the baby is day 6 of life, I'll give 40 meals 3 hourly to help hydrate. So how did you get the 40 meals? How would you get the 40 meals? 3 hourly. Tell us how you arrive at 40. And then, of course, is that breastfeeding via NG or parenteral? No, parenteral is number 4, is the next question. So we haven't reached at parenteral. Dennis, we are still on the enteral feeds, of course. So 60 meals per day multiplied by kg body weight divided by frequency of feeding as a start. Okay, so let's see what guideline is saying. Okay. I don't know if I'll be able to get the presentation. Grace, are you in today? Or your power decided to go out? So let me project to you what Grace had presented so that we can look at it and then see what it means. Time is running out. I need to wind up. Entire screen. So Grace had shared something on the algorithm that we would like to see. Of course, we have feeding stable and well babies, birth weight less than 1.3, so versus equal or more than 1.5 kg. So assess the baby shortly after birth, of course, less than that. Weight equal or more than 15 grams, able to breastfeed. So we are in this category. If no, feed by cup based on infants' hunger cues, breastfeed on demand based on infants' hunger cues. Then, of course, example, if 1,000 grams, so this is less than 1 kg, of course, you start at 80 and all that, you go down. As you see, you calculate the frequency. Of course, you add 20. But something important here to note is that you start feed with 5 meals. Express breast milk and increase by 5 each 3-hourly feed until you reach 3-hourly feed volume, which is achieved. So this will help you again to remember. We said the stomach of babies is quite small, and you might not be able to. You need to start cautious feeding. So you start at 5 meals, even though you find that you require 10 meals 3-hourly. The first feed should be 5 meals, then the next one is 10 meals for a baby who is 1 kg. So it is important that is well taken care of to avoid neck. It's important. Then, of course, 3-hourly NGT express breast milk feed volume in meals. For this is now stable newborns with birth weight 1,000 to 1.4. This is how you'll be giving. Then, of course, we have fluids and for unstable neonates. I don't want to go deeper into that. So equal or greater than 1.5, we start at 60 meals per kg per day that is for IVF. But again, I'll agree with what you say, that we start with 60. Then, of course, we increase as we go by. Because again, remember, if we start higher, remember, we might experience refeeding syndrome for babies who have not been feeding for that matter. So you don't really start at a higher meals. Remember, the baby has not been breastfeeding well. So if you start at a higher meals, the baby will end up having the feeding syndrome. So you start at 60, then of course you increase as feeding goes by. All right. So for parenterals, the last question. Sorry, let me just stop presenting so I can go back to our. What are the possible indicators for parenteral and calculate the parenteral? So what are the possible indicators? What will lead you to start this baby on parenteral feeds? Let me hear what people are saying. Anybody? Anybody either in the chat? Time is running. We need to wind up. For parenterals, what could now we've completed the enteral feeding. Now we are going to parenterals. So what could be the first indication that will lead you now to go to the parenteral feeds, and how will you calculate? Poor breastfeeding, stroke attachment. Laina, can that take you from enteral to parenteral? Remember, we are still discussing the same case study. Who are sucking. Of course, the baby maybe is not sucking. We are doing EBM, express breast milk, because of the baby is sick, might not be able to suckle adequately. Acute kidney injury, when the GIT is not functioning well. So what is that condition? Of course, intractable vomiting. Of course, if you have neck, you might end up putting this baby on parenteral nutrition. And again, other conditions, other related medical conditions that has made the malabsorption is there, in feeding, feeding intolerance, the baby is having lack of bowel sounds, of course. So anything that is going to affect the GIT, either neck, malabsorption, all that, then you need to consider parenteral feeding. So now we are in parenteral feeding. So how much will you give? Because of time, I just want us to concentrate on how much of calorie you are going to give to this patient based on what we learned yesterday. Let me see if the good students who remember what Grace taught yesterday. Let's start calculating calories. How many energy requirement will you give this baby? Let's see what people are saying. 120 kilocalorie per kg. Sylvia, can you unmute and talk? If you can. Why 120? Let me see what other people are saying. People are quiet. Oh, yeah, go ahead. Go ahead, Sylvia. How are you?
Fine, thank you. I'll treat this patient as a prem. And for prem, kilocalories is between 115 to 130 kcals per kg. That is why I picked 120.
Oh, okay. Great. Anybody of the contrary opinion? How much kilocalorie will you give? How much will you calculate the energy? You can unmute and give your answer. There's 100 meals per kg per day. And Muchina. Tunaongelea energy hapa. 100 meals. If the enteral feeds are not sufficient to meet the requirement of the infant, of course, that one is you can do. 100 kcals, 90 kgs. Okay, I mean I thought maybe, Caroline, I thought you mean kcal. Fine, let me rush very fast to what we learned yesterday, because I'm seeing time is going very fast and I don't want to take much of your time. In my more clarification, Grace will be able to tackle tomorrow, but allow me to share the screen so that we revise what we had learned previously. So, oh, sorry. It's not that one. It's misbehaving. Why? Let me brush through the guidelines, what we learned yesterday, so that we... So energy requirements. So due to preterm infants' limited nutritional stores, the goal is to initiate nutritional support as soon as possible and achieve early energy accretion. A number of studies have demonstrated that the provision of adequate quantities of protein and energy can be significantly improved postnatal growth in preterm infants. However, it must be borne in mind that number of conditions and treatment, including, can affect the energy needs of preterm, of course, blah, blah, blah. So energy requirements of infants should cover energy needs for basal metabolic function, energy expended for physical activity. This one Grace expanded yesterday. Diet, including thermogenesis, energy for new tissue growth, and of course, energy loss in stool and urine. Energy expenditure is in most preterm infants commences at about 35 to 55 kcal per kg per day, and increases over the first 2 weeks of life to about 70 kcal per kg per day by 1 month of age. For term infant, this is 45 to 50 kcal per day, increasing to 60, and that energy requirement for growth are 3 to 5 kcal per grams per day. Very preterm infants will therefore have additional energy need of 50 to 70 kcal per kg per day, suggesting a total enteral energy intake of up to 120 kg per day is required to facilitate maximum protein accretion and appropriate uterine growth. So 30 to 40 kcal per kg per day with a total of up to 90 kcal for term infants. Since the amino acid component is required for tissue repair and new tissue synthesis, the majority of energy provided in parenteral should be from non-protein, non-nitrogen sources, e.g. lipid and carbohydrates. So I hope that really is okay. So recommendation for preterm and term infants: if starting parenteral within the first 4 days of life, give a starting range of 40 to 60 kcal per kg per day, gradually increasing over a small number of days. Most preterm infants will meet their energy requirements and approximately intrauterine lean body mass and growth rates when provided with maintenance level of up to 120. So most term infants will meet their energy requirements and approximately intrauterine lean body mass when provided with a maintenance of 90. So for preterm and term infant, if starting parenteral more than 4 days after birth, give maintenance level from the first day of parenteral. So indeed, Sylvia, you are right, because we are day 6, so therefore we'll start at 120. But remember, if we are starting for within the first 4 days, we start at 40 to 60. I hope that is well understood. I wanted us just to have a recap of the energy, but again, the aspect of proteins and all that. So I don't want to go through that for today. So because of time, I think we stop there, unless now we'll have questions that we can go through before. Any question that we have not answered? I have seen 3 questions, which I if you allow me, we preserve them for tomorrow because of time. We are already 19 minutes past time, and I don't want to take much of your time. Any burning question before we end? Was the session helpful? Did you learn something?
Yes, we have learned.
Okay, great. All right, so thank you very much for those who have attended today. We still remind you that next week we are starting a series of pediatric nutrition oncology, and we'll really, really love you to join us for this important session. And we look forward to having you. I'll be able to take you through the pediatric nutrition oncology. September is a month of pediatric cancer, and we will be glad to really join to see all of you in this forum. Otherwise, thank you very much. I think we can end the session there unless there's any burning question. Take it back to Milan. If you are around Milan, maybe you can close up the session. Thank you. Milan, if you can hear. You can unmute and have a closing remarks. Milan, we can't hear you really. Okay. So I think maybe Milan is engaged. He's not able to have a closing remarks. So see you tomorrow. I hopefully Grace will be available, and of course we look forward to having more session tomorrow. So see you tomorrow, same time, same place. Have a lovely evening. Goodbye, everybody. Thank you.